This voiceover is going to cover kidney transplants, and it's just a few slides just to kind of prepare you for your next exam. Transplant from a deceased donor usually requires a prolonged waiting period. The differences in waiting time are going to depend on age, gender, and race. Average wait times in the U.S. for a cadaveric kidney to become available are approximately 2 to 5 years. More than 93,000 patients are currently awaiting kidney transplants. Fewer than 25% ever receive a kidney, and out of all organ transplants is the most successful. 1-year statistics show that there's a 90% survival rate with cadaver transplants and a 95% survival rate with live donor transplants. Advantages of kidney transplantation over dialysis include it reverses many of the pathophysiologic changes associated with renal failure. It eliminates the dependence on dialysis, and in the long run, it's less expensive than dialysis after the first year. Candidacy, determined by a variety of medical and psychosocial factors that vary among transplant centers. Some transplant programs exclude patients who are morbidly obese or who continue to smoke, despite smoking cessation interventions. Certain patients, particularly those with cardiovascular disease and diabetes, are considered high risk and must be carefully evaluated and then monitored closely after transplant. For a small number of patients who are approaching end-stage renal disease, preemptive transplantation before dialysis is required is possible if a living donor is available. Contraindications to transplant include disseminated or metastatic malignancies, undertreated cardiac disease, chronic respiratory failure, extensive peripheral vascular disease, chronic infections, and unresolved psychosocial disorders. At one time, patients who had HIV were denied the opportunity for kidney transplant. However, centers that have included HIV-infected patients demonstrate graft and patient survival rates similar to those in the HIV-negative population. On the basis of evaluation, procedures may be required before transplant. These include coronary artery bypass, cholecystectomy, bilateral nephrectomies, and coronary artery bypass graft is indicated for advanced coronary artery disease. Cholecystectomy may be necessary for patients with a history of gallstones or cholecystitis, and on rare occasions, the bilateral nephrectomies may be necessary for patients who have refractory hypertension, recurrent UTIs, or kidneys that are grossly enlarged as a result of polycystic kidney disease. Donor sources for the transplanted organ include deceased donors with compatible blood type, blood relatives, emotionally related living donors, altruistic living donors, or paired organ donation. Paired organ donation is the practice of matching biologically incompatible donor-recipient pairs to enable transplant in both candidates with a well-matched organ. This occurs when one donor-recipient pair who are biologically incompatible or poorly matched with each other find one or more donor-recipient pairs with whom they can exchange kidneys. Expanding the living donor pool is one of the best possibilities for decreasing the size of the waiting list and reducing wait times for people needing a deceased donor. The living donor process is an extensive multidisciplinary evaluation. They look at the psychosocial and financial evaluations. The advantages is that it's better patient and graft survival rates, immediate organ availability, and a minimal cold time. Cross matches are done at the time of the evaluation and about a week before the transplant to ensure that no antibodies to the donor are present or that the antibody titer is below the allowed level. Several examples of laboratory studies that are done prior to transplant is a 24-hour urine for creatinine clearance, total protein, a CBC chemistry, and other infectious panels such as hepatitis, HIV, and CMV. In addition, an ECG or EKG and chest X-ray are done. Renal ultrasound and arteriography, or a three-dimensional CAT scan, are performed to ensure that the blood vessels supplying each kidney are adequate to ensure that there are no anomalies and determine which kidney will be removed. A transplant psychologist or social worker will determine if the donor is emotionally stable and is able to deal with the issues related to organ donation. That's a key component of this slide. Deceased kidney donors are relatively healthy individuals. They've just suffered an irreversible brain injury and are declared brain dead. The brain dead donor must have effective cardiovascular function and be supported on a ventilator to preserve their organs. Even if the donor carried a signed donor card, permission from the donor's next legal kin is still requested after brain death is determined. The kidneys are removed and can be preserved for up to 72 hours, but most surgeons prefer to transplant kidneys before the cold time reaches 24 hours. And the cold time can be defined as the time outside of the body when being transported from the deceased donor to the recipient. The surgical procedure includes a nephrectomy performed by a urologist or transplant surgeon on the live donor. It begins 1 or 2 hours before the recipient's surgery is started. A rib may be removed to allow adequate view for the surgeon, and it takes about 3 hours. The recipient is then surgically prepared for the kidney transplant in a nearby operating room. The live donor procedure can include either a laparoscopic or a conventional approach. The laparoscopic approach significantly decreases hospital stay, pain, operative blood loss, debilitation, and length of time off work. For these reasons, the number of people willing to donate a kidney has increased significantly. The recipient, the organ usually is placed extraperitoneal in the iliac fossa. The right iliac fossa is preferred. Before the incision, a Foley catheter is placed into the bladder. Antibiotic solution is instilled, which distends the bladder, and it decreases the risk of infection. During the surgical procedure, there is rapid revascularization, which is critical. The donor artery is anastomosed to the recipient's external iliac artery, and the donor vein is anastomosed to the recipient's external iliac vein. When the anastomosis is complete, the clamps are released and blood flow is reestablished. Urine may begin to flow, or a diuretic may be given quickly. The surgery of the actual transplanted organ takes somewhere between 3 to 4 hours. Prior to the surgery, the preoperative care requires an emotional and physical preparation. They may talk about immunosuppressant drugs that are required afterwards, and as we mentioned a couple slides prior, they are going to require an EKG, chest X-ray, and lab studies. Often, dialysis may be required before surgery for any significant problems such as fluid overload or hyperkalemia in the recipient of the organ. A patient on PD or peritoneal dialysis may empty the peritoneal cavity of all dialysis solution. The vascular access extremity in somebody that has a venous access device for hemo should be labeled dialysis access, no procedures, to prevent the use of the affected extremity for BP measurements, blood draws, or IV infusions before the patient undergoes surgery. And the live donor postoperatively, care is similar to that for an open laparoscopic nephrectomy. They need to closely monitor the patient's renal function and hemoglobin and hematocrit. The donor who has had an open nephrectomy may experience greater pain than the donor who has had a laparoscopic procedure. In general, all donors have more pain than the recipients do. Donors who have undergone an open surgical approach are ready to be discharged from the hospital in 3 to 5 days and can usually return to work in 6 to 8 weeks. Laparoscopic donors are able to be discharged from the hospital in 2 to 4 days and can return to work in 4 to 6 weeks. Post-op care of the recipient quickly assesses urine output and electrolyte balance. We need to maintain fluid electrolyte balance. Large volumes of urine after transplantation can occur, as the new kidney's ability to filter the excess BUN. Abundance of fluids during operation is key, and we need to be watching for renal tubular dysfunction. Often during the immediate post-op period, urine output during this phase may be as high as 1 liter per hour and can gradually decrease as the BUN and serum creatinine levels return to normal. In the recipient, we need to look for urine output must be replaced with fluids milliliter by milliliter per hour. So a 1-to-1 ratio is what we need to replace the output of urine. We need to closely monitor the urine output, and we need to monitor for any signs and symptoms of acute tubular necrosis, which may manifest as oliguria. These patients may necessitate dialysis. We need to make sure that we maintain catheter patency if they have a central line, and central venous pressure readings, or CVPs, are essential for monitoring postoperative fluid status. Acute tubular necrosis can occur because of prolonged cold ischemic times and the use of marginal cadaveric donors if they were medically suboptimal prior to start with. A sudden decrease in urine output in the early postoperative period is a cause for concern, and I would remember that. It may be due to dehydration, if they've had excessive urine output in the earlier period, if it means rejection, there is a leak at the anastomosis sites, or if there's an obstruction. Post-op teaching should include the prevention and treatment of rejection, infection, and complications of surgery, and the purpose and side effects of immunosuppressant medications. The goals of immunosuppressive therapy after surgery is to suppress the immune response to the new organ, yet prevent overwhelming infection. Hyperacute rejection can occur minutes to hours after transplant when the blood vessels are rapidly destroyed. It occurs because people had pre-existing antibodies against transplanted organ. There is no treatment, the organ is removed, and the patient must go back on dialysis. With an acute rejection that occurs days to months, the recipient develops antibodies to the transplanted organ. This is somewhat common, especially with deceased donors. It's usually reversible with additional doses of immunosuppressant therapy. The chronic rejection stage occurs over months to years and is irreversible. There are unknown reasons or from repeated episodes of acute rejection. It results in fibrosis and scarring of the kidneys and glomerulonephropathy. Treatment is supportive and is not associated with optimistic of acute rejection. Symptoms of rejection include pain at the site, flu-like symptoms, fever, weight change, swelling, heart rate changes, and reduced urine output. And I would remember that. This is an extremely important slide. Some other important complications to remember for transplant of the kidney is infections. Most common infections observed in the first month: pneumonia, wound infections, infections of a prior central line, UTIs. Underlying systemic illnesses such as diabetes mellitus or systemic lupus can further compound the negative effects on the immune system. Fungal and viral infections are not uncommon because of the patient's immunosuppressed state, taking the immunosuppressant drugs. Fungal infections are difficult to treat and they necessitate prolonged treatment periods and often involve the administration of nephrotoxic drugs. Transplant recipients usually receive a prophylactic antifungal drugs such as Miselex, diflucan, and bandicam to prevent these infections. Primary infections occur as new infections after transplantation from an exogenous source, such as the donated organ or a blood transfusion. Reactivation occurs when a dormant virus exists in a patient and emerges from a dormancy after transplantation because of immunosuppression. If a recipient has never had CMV and receives an organ from a donor with a history of CMV, antiviral prophylaxis should be administered. Cardiovascular disease is another key complication after transplantation. Transplant recipients have increased incidence of atherosclerotic vascular disease. The immunosuppressants can actually worsen hypertension and hyperlipidemia. Patients need to strictly adhere to antihypertensive regimens, and it's the leading cause of death after renal transplant. Hypertension, dyslipidemia, diabetes, smoking, and infections can all contribute to the increase in cardiovascular risk. The immunosuppressants, as we mentioned, can worsen hypertension and dyslipidemia, so we need to make sure that we teach the patient to control these risk factors, such as elevated cholesterol, triglycerides, and they need to maintain good glycemic control and maintain an ideal body weight. The overall incidence of malignancy in a post-transplant patient in the general population is high. The most common types of cancer after transplant are basal and squamous cell carcinoma of the skin, Hodgkin's and non-Hodgkin's lymphoma, and Kaposi sarcoma. Other cancers for these patients are at increased risk for the liver, stomach, the vulva, and the penis. Malignancies, the primary cause is the immunosuppressant therapy or drugs. It's imperative that these patients are regularly screened for cancers and that they make sure that they adhere to preventative care, such as protective clothing and sunscreen when they're outside. Patients must be informed before transplant if they have a disease that is known to recur. Recurrence of the original disease includes diabetic nephropathy, glomerulonephritis, and other focal segmental sclerosis. Some of the corticosteroid-related complications from immunosuppression is the septic necrosis of the hips, knees, and other joints, peptic ulcer disease, GI bleeds, glucose intolerance and diabetes from the increased release of the gluconeogenesis, increased release of stored glucose, dyslipidemia, cataracts, and also an increased incidence of infection and malignancy. So the goals of somebody who's had a kidney transplant is to maintain an ideal body weight, acceptance and management of the chronic disease, prevent and maintain no infections, no edema, and to maintain normal labs.